warm welcome to your house.
Thanks, Jess. Can you guys hear me okay? Mic is better, no reverberation. All right. So I've got a lot to say. I'm going to truncate it down as much as possible, but honestly, nothing here is life and death. If you guys have to leave, but I will try to kind of keep it within that time range. So I hate talking about myself. Fortunately, I love talking about medicine. And I could be up here all day talking about what I do and how medicine is evolving, medicine 2.0 or 3.0. But I do want to give you a little bit of background. So I created this just sort of like a graphical biography in a sense, just to kind of frame my journey, which might be a little atypical. Actually, this took way too much time. But I thought it was interesting to sort of track like happiness as a function of time and where I went. But this is where I started off at Boston College, right? You're worth nothing, but you're growing and you get tremendous joy out of what you do, right? I had loved UCSB, had blast in Santa Barbara, got a master's degree, felt fabulous. Went on to get my medical degree and I was in love. I mean, I would go back to medical school in a heartbeat. That was my thing, just studying in coffee shops. Residency was the same thing though. I loved it because you're learning. And then boom, there's the real world and there's private practice. So what's interesting is you watch your cash flow go down the toilet and then all of a sudden you get a nice like big boy paycheck and you call this the golden handcuffs. So, you say, hey, wow, I can start living like a human being, but I'm miserable. And how long does that last? Unfortunately, a lifetime for some people. For me, it took 5 years to break out of it. I call it Concierge Medicine 1.0, Concierge Doc 1.0, because this is where I moved to Santa Barbara and worked for another doctor for a year. Yeah, so I took a bit of a pay cut. My quality of life went up. It was a good stepping stone, but it wasn't my personality, right? I mean, if you're gonna be a doctor, you wanna grow with your patients. You want patients that fit your personality. You don't wanna take over a retiring doctor's patient panel. It's just not your thing. Not to mention, no offense to Medicare, that's not my thing either. I love the fit, the active, the healthy, like sort of the patients that you can really like work into the lifestyle that you want to bring to them. And those that are participatory, really like patients that come into my practice, they're active engagers, right? They don't come in there with a blank slate and say, Dr. V, fix me. They come in with all their data and you have to help organize it with them. So they're extremely proactive. And I love that. And so, as I've grown into what I say Concierge Doc 2.0, my creativity has really sort of flourished, I think. My autonomy is going through the roof. I hate being told what to do. And I think that was part of my problem if I had to psychoanalyze myself. So here I am now, and I want to give a little plug on what I'm up to. So Concierge Medicine is my feeder. I love it. I've got 200 patients. I've got my wait list, like I said. I enjoy what I do, and I'm trying to grow. I'm trying to bring on another physician so I can continue to grow, ultimately bring on a third physician so then I can minimize the sort of the direct primary care that I handle and think about wellness planning. So my passion is truly sitting down with a patient with a cup of coffee or a cappuccino, spread out all your data, and then we come up with a plan. And it's extremely complex, three-dimensional plan. So what I want to talk about today in our limited time was what I do in that plan and period. What does an executive wellness exam mean to me? And we'll go through it quickly, I get it. Here are the other things that I'm about that I love. So I'm in the process right now with some investors to create an imaging center. I want to compete with Pueblo Radiology in Montecito, but not to the same degree or purpose. There's a lot of new technology coming out. This PET CT, there's a SPECT scan. You can use radioactive nucleotides to do cardiac testing. You can look for prostate cancer called a PMSA scan. There's a lot of new technology in the imaging world that Santa Barbara doesn't have, and we have to route them to Cedars. So I want to capture that market and make Santa Barbara relevant again. It sounds weird to say that, but from a medical mecca, the top people are still sort of traditionally out of Cedars or UCLA. I also want to get back to the community, hence the insurance billing thing, although this is cash only. I co-own a side hustle with Mary's Potions. She has Sage IV, but we co-own Sage Aesthetics. So we're trying to bring on Botox fillers and some other fun stuff. We have a weight management thing where we use Mounjaro, subcutaneous, but not just dispense it like this, track these patients, make it analytical, and make it safe, because patients are getting it from the community with no oversight. This I'm really excited about. There's a new company that I'm forming with another business partner, HealthSpan Montecito. I want to bring the technology aspect of internal medicine into the primary care, and this is sort of my entrance into longevity medicine. So this is being created as we speak. The place is being renovated. It's right by Manchester Capitol on Coast Village Road. Stop by. This is being built right now. The VO2 Max is being put together. The DEXA scan was put together yesterday. So I want to do higher level fitness testing. So test, initiate some sort of treatment protocol, test, and then weave it in with your primary care doctor. I don't know why this sort of health and wellness aspect is not paramount to your physical exam. I mean, it's all part of primary care, and so I just want to make it more of a part of primary care. We have a couple sort of like Rocky IV equipment pieces in there to implement some of these changes. The consultations I'll be doing, and sort of just like, not everybody wants to sign up for concierge medicine, but people probably want consultations just regarding their overall fitness status, and we can weave in some relevant medicine. This is franchisable. Cash flow is limited with concierge medicine, right? Because I'm just one person. I can't have a Montecito Concierge Medicine, Santa Monica. I mean, maybe, but I don't anticipate to do a whole lot with that. Virtual urgent care, I've got a nurse practitioner who's a rock star who was with me to sort of scheme, how can we bring Montecito Concierge Medicine? There's a ton of patients that call and they just need to talk something out. They're looking for guidance. It's not so much, hey, I have chest pain, what should I do? But you can still offer guidance, go to the ER. Or, I can guide them and say, check your vital signs. This is how I think about it. Here's how my brain works. And this is a scalable business opportunity. Right now I'm trying to figure out some P&Ls to see what the budget should be, because the market is high for this. I also work with an interventional radiologist, this rock star guy, Jamil Mwasher, who now works in my clinic. He does vein procedures and we split the profits. I also see him paramount into my imaging center. He's gonna be reading our full body MR scans and also our DEXA scans. This is interesting because a big part of what I do, sometimes I feel like I should walk around Montecito just like hugging babies, but it's establishing partnerships and the right partnerships. And seriously, I mean, it's a big part of what I do, and it's not just local. It's, patients ask me, who's the best in LA? I can go anywhere in the world, where should I get my knee done? So, I leverage my patient panel, the opportunity set forth to call whoever I can, grab coffee with whoever I can, and establish a relationship so I can shoot a quick little text message out. This is interesting. My new game is to try to sign up the Montecito hotels into my concierge practice, which is interesting. When I get a call on Saturday night from San Ysidro Ranch and they want a doctor to come see a client, it makes them look great. I don't really want to do it, but it's sort of a marketing opportunity for me. I'm at the point right now where I'm playing hardball, so I don't answer it, and then I call them back the next day and I say, hey, I shoot out an email about signing up and having a retainer. I can guarantee coverage 24/7 for your hotel. Me, a nurse practitioner, and a nurse, whatever you need, we can guarantee coverage. Feels bad, makes you look bad by not responding to that call, huh? Right? So this is another thing that I'm trying to play. We'll see how that goes. But I'll tell you, concierge medicine, the hardest part is I'm wearing two hats. I'm doing all this sort of lifestyle planning. I want to frame this all into a health and wellness plan. And then I handle the coughs and colds and the Friday night text messages and the refills on medications and things. I don't think that's the best use of my time. So my next venture would be to bring on an associate, a partner to handle the day-to-day stuff, whereas I meet with patients and almost like a financial planner. I come up with a scheme for them and then delegate the things that don't need to pass my hands. Okay, so the mojo for my practice is I put a lot of upfront attention into wellness modeling. I'm extremely goal-oriented, and it infuriates me when problems aren't solved. Here's a personal, true example. Sitting on the couch with my mom, and I'm looking over her blood work, and I hey, Mom, your LDL is 170. I remember seeing this when I was in Boston College. That was 20-something years ago. Your LDL is still 170, Mom. What are your thoughts on that, right? Your A1C is 7.2. Do you plan on handling that? And so much of modern medicine right now is just delay, drag it out. You see your doctor once a year and you tell your doctor, I'm working on my diet and exercise, and they believe it, probably because it's easier to believe it than to act on it. And then next year comes out and it's the same thing. Nothing ever gets accomplished. Remember, because I don't bill insurance, I want to get them to this status as fast as possible. And how do I gauge success? If I'm sitting there on a Tuesday morning at Kage Coffee on my laptop, framing my other projects, and it's quiet, right? You can hear a pin drop in my office. The staff is there, my little doggy's running around, all is well, nothing's happening, then I know I'm doing a good job. And that's the whole point. It's just sort of mutually beneficial, and it's very harmonious. And it's a beautiful thing. It doesn't exist that way. Success for maybe another doctor's practice is, hey, I saw 30 patients today. I've worked with doctors, if they had an open time slot, they would have their nurses call random patients to fill slots. It's not about outcomes, it's about sort of volume. All right, so deconstructing it, this is what I put in my yearly physical. I crossed these off because I knew we wouldn't have time to talk about it, and I'll probably have to cross off a few more, which leaves not a whole lot. But more so, I want to tell you what some of the challenges are for me. This didn't obviously come out appropriate, but you know, I don't know, even 30 years ago, the doctor comes in with a white coat, they stand over you and they feed you knowledge. It's not like that anymore. It's a partnership, it's an association. You shake hands, you look your patient in the eye and you say, okay, I'm here to guide you. It's a whole different paradigm. Not to mention, patients come into the interaction with a whole lot of maybe relevant biases. They have their own ideas, they have their own autonomy. They're very smart patients that walk through my door, CEOs, executives, they can get education and knowledge wherever they want. They're afraid of certain things, they're getting advice from their neighbors. ChatGPT can give them most of the same data. They may not know how to interpret it in their bigger context, but that's where I come in. And hey, I've got my own biases. This is what I learned in medical school, but I'm constantly changing. This stands for continuing medical education. So every year I go to conferences and I see what's new in my field, and it's not a lot. I mean, internal medicine moves like a stale pace. Population guidelines, you have to apply that to your patient, and of course your personal experiences in mind. So we amalgamate it and we get sort of this personalized wellness plan. But I should say too that patients come in now more than ever with alternative providers. They come in with naturopaths, they come in with integrative doctors. And the classic Western medicine doctor rolls their eyes at that and poo-poos it, probably because they don't understand it, they don't know it, and they're maybe afraid of it. But it's part of the game. And the more you sort of take patients and ostracize them from that paradigm, they're not gonna open to you. There's no therapeutic alliance. They're gonna get their information elsewhere. You'll see them once a year. They won't divulge things to you. So I spent a lot of time spinning my wheels, learning as much as these guys can do and as much as they know in their specialty tests, so I can integrate in what I do. And when they tell me they have an alternative provider, I get them on the phone and I say, hey, we have a team. I'm excited to be part of your team. And we can all work together to achieve a better outcome. Some people don't like to play nice, and I know internal medicine doctors don't like other doctors in the mix. And I've had the same sort of outcome with integrative physicians as well. But this is the biggest challenge of all, is that nothing in my world is black and white. We live in the grays. Nothing is yes or no. It's all non-binary. It's not blah, 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 blah. Really, like, you get all this information skewed at you, and you have to make a decision for that patient in front of you. So I love this little picture because it kind of shows as like a vector format with all these different forces going in different directions. But even the simplest medication, like even like B12, has a very wide therapeutic index. It's not narrow like rapamycin. It's hard to get B12 toxicity, right? What's the benefit? Well, if you have a neuropathy or if you have memory problems, this could be extraordinary. And what's the weighted evidence? Maybe you don't have a randomized control trial. But hey, you know what? You can't create a randomized control trial for everything there is, but you have to make a game time decision based on your patient. So this is a struggle I deal with every day, and a big part of what I do is just talking it out. So the nature of my game is health span. I mean, honestly, I talk about longevity. I don't really care to keep patients alive to 120, 130, although there is data that might be possible in the near future. I want to keep that curve as high up as possible and then fiery crash, right? So I want to have patients as high functioning as possible, and then they pass away in their sleep or doing something that they love to do. Right? So this is the nature of the game, and this is modern medicine. You get them up, they turn 40s, they start feeling their aches and pains, things start to break down in the last 20, 30 years. Or God, I went on a hip fracture. And then a third of patients pass away in a year after a hip fracture. So the nature of my game is to protect this house, and seriously, like, get it done as quickly as possible and put it on autopilot. I mean, it's really not that challenging. So I try to get everybody over here, no matter what metric you're talking about. There's no reason why patients should be buzzing around the mean. But don't forget that when doctors talk to you about, hey, 10% probability of X, Y, and Z, that doesn't necessarily mean that applies to you. That's population data. You know, I mean, what's the probability of winning the lottery? Somebody wins it, right? So a bell curve is just it's a generalized distribution that gives you a sense of probability. But, you know, if there's a very low probability of something happening, like an osteosarcoma, some poor person is going to get that, and they're going to say, doc, right? I mean, why did I get this? And on the same sort of other spectrum, the low probability events can happen. This comes into relevance with, say, prostate cancer. Say 10% of prostate cancers tend to be invasive. 90% seem to be you grow old with the prostate cancer. You don't have to worry about it. So there's some advocates saying, hey, because it's only 10%, we should stop screening. Whereas all my patients, really, I had this conversation with one of my patients who's not here right now, but he said, Dr. V, why would anybody not want to screen for something? And I say, okay, I don't necessarily agree with not screening, but this is what they're thinking. It's not going to happen to me, right? And modern medicine, what they do in guidelines, especially for prostate cancer, is say, if they're low risk, you have a joint discussion with them. And some people choose not to do it, but you know, to be honest with you, I mean, here's sort of the framework that I'm dealing with, is that modern medicine and guidelines see this as something that can cause anxiety and should be avoided in certain patients. So if the patient can't handle the news you're going to give them, or you know, if the patient doesn't sort of have the educational status or the emotional status to kind of handle bad news, then use that as an argument to not screen for certain things. It doesn't fly in my world. We're all about data, and this is sort of another little plug, right? I know it's 7:32 right now. Physicians that don't understand things usually say don't do things. This comes up with relevance in terms of the full body MR. So I've been doing full body MRIs here in Montecito and Santa Barbara, probably from the beginning. Pueblo Radiology does them. And I got several phone calls from other doctors, even like a pulmonologist called me and said, hey, Dr. V, you're aware that you're going to get a lot of noise. And I was like, okay, you know, statistical noise with full body MRs, I mean, you're going to get stuff that might not be clinically relevant. But here's the thing about modern medicine. As you start doing more of these scans, you learn what's clinically relevant. As Per Nuvo starts getting upwards of, hey, you know, they run 10,000, 20,000, 50,000 scans, they're going to start to learn these algorithms, run it through AI, and cancel out the noise, right? So if there's an unknown in medicine, we call it an incidentaloma, which is like a fearful thing that you didn't want to uncover in modern medicine. The doctor says we shouldn't scan because we don't want that information. Whereas the next generation medicine is scan the hell out of them, organize your data, and then use machine learning, all sort of stuff to make sense of this data. But I say this as such an important feature right now because when you're talking about statistics with patients, there is definitely a misunderstanding of the statistics behind a bell curve. So I'm going to rattle through this. Phase 1 of my health and wellness assessment for patients is to figure out your genetic risk and your foundation. Not everybody needs to do genetic testing, right? Was a 72-year-old going to come in and do genetic testing? But realistically, you need to know what you're dealing with. And I'll sit down with a patient over that cup of coffee and we go through their whole health history and ask about their mom, their grandparents, what are we dealing with, right? And that goes in our algorithm. But what I love about this new fun stuff is, man, you can blast somebody's entire genome and start looking at the complex interplay of genes. This is different than 23andMe where you have, hey, you know, ApoE4 mutation. We're talking about how genes interact. And you get these cool things like odd ratios. So for instance, there's ApoE4 I talked about as a 3x to 4x increase in Alzheimer's disease. But if you also have a concomitant COX-1 mutation, that goes to 5.3 times likely of getting Alzheimer's disease. If you give this information to a 25-year-old, right, this is medicine 2.0 versus 3.0. Should you not give that information to the person because we don't have treatment for Alzheimer's disease? Not yet. But they might very well change their behavior. If somebody told me that, hey, listen, you know, in 30, 40 years you might develop Alzheimer's and you're at a higher risk, you be sure as hell that I'm going to take every action now. I'm going to stop drinking alcohol. I'm going to optimize my sleep. I'm going to do things that we know to do. And I might even get on a supplement regimen. And some of these fancy genomics tests even offer evidence-based supplements that can help support different enzymatic mutations. So it's powerful. It's cool stuff. This is the current standard of care to how an internal medicine doctor gauges cardiovascular risk. It's complete nonsense. Complete nonsense. Like it doesn't even factor in LDL cholesterol. So this is my information, by the way. And you get an output that says 10-year risk of heart attack, 2.9%. See you again in a year, Vigs. That's the standard of care. That's seriously it. I mean, it's really designed, should you be on a statin if it's over 7.5% or not? It's not, hey, you're developing risk factors, you got, you're obese, you got metabolic syndrome, all this kind of stuff. We need to start spinning this around before you develop plaque. The answer is, are you gonna have a heart attack in 10 years? Who plans on having a heart attack at 51? Like, why is this the end game? But that's what doctors do. This is what I do. So when I'm looking at cardiac risk evaluation, I look at all the things humanly possible that can be correlated to that cardiovascular risk. If you're going to give somebody a probability, the more relevant variables within that equation make your output more relevant. So I look at fancy modifiable insulin resistance, metabolic risk factors. I look at physical activity, VO2 max testing, which we're going to run through our healthspan Montecito place. Visceral adiposity tissue. This is picked up either from full body MR imaging or or a DEXA body composition scan. LDL cholesterol is archaic. Now there's LDL-P particle number, apolipoprotein B, LP(a), which infers genetic risk. I don't have time to run through all of this in detail, but you can see visually that there's so much more to the equation than this sort of generic medicine 2.0. So top 2 killers for my patient panel, cancers and heart disease. So we go bullish into each one. And I mean, man, my patients, this is me again, by the way, love this data tracking. You have reds and yellows, you institute an intervention, and you repeat it. And it's so cool and rewarding to see what you're doing translated into an outcome change, right? And then you put it on autopilot. And this can be herbal medications, this could be lifestyle changes, this could be tweaking your nutritional status. But once I do this full analysis, I give patients these report cards essentially, and then we can use that to track how they're doing. And it's not good enough to get a good report card, you have to maintain that too. All right, so I'm gonna pass over this because of time. I'm gonna tell you this really, so modern medicine right now is, are you about to bust a blood clot? Are you really about to have a coronary? You're gonna have a heart attack? This is when you intervene, you cath patients, you fix it. When I was in residency, the only way we can evaluate someone's heart was to put them on a treadmill. We had that in my office. We put them on a stress test, a stress echo. Now we have fancy scans. So realistically, if I were to send a 30-year-old in for a stress echo, I know it's gonna be normal because you have to have pretty far advanced disease to have abnormalities on a stress test. So the standard of care is to not do anything. But now if somebody has genetic risk factors, you see that they have gene mutations that lend them to higher risk of having cardiovascular disease, their family members are dying early, and they have high ApoB, LP(a), all these little markers, I can do a very low radiation coronary calcium CAT scan on them. And I do that for a lot of my patients that turn 40 to get a baseline assessment and see where you are. Remember, number is only as good as risk evaluation. You can have low risk and still have plaque. You can have high risk and have no plaque. There are still variables I don't know. But at some point you want an image to see, is there actual disease? So has anybody heard of this CCTA imaging or this thing called a Clearly study? All right, I want to send Gary Dorfman for this, by the way. But it's this new fancy cardiac scan. I mean, honestly, like it's incredible. So calcific plaque comes up on a coronary calcium CT scan. Gummy plaque comes up when you add contrast and time it with the heartbeat. And then you have this new AI algorithm that overlays it that adds machine learning into the mix. So then you start trending. So think about the trendability of data. You can trend LDLs over time. You have an intervention, you trend it. You can visualize your heart and trend non-calcified gummy plaque. This stuff is reversible. This stuff is what it is. It's like the gunk in your pipes. Statins stabilize this and lower your risk of having a rupture, i.e. a heart attack. But this non-calcific plaque can go down significantly with the right intervention. So how cool is that, that you can actually see these things changing? And it's incredible. You can three-dimensionally rotate these scans, look at flow dynamics in each vessel, and then use the computer to come up with those scores. Santa Barbara doesn't have it. I want to build one here. Right now I send patients to Cedars. I would say this, because we're running out of time. I'm going to wrap up after just cancer screening, and I'll just highlight just a few things. Again, mindful of time. But top 2 things that kill my patients, heart disease and cancers. Nobody wants to be blindsided by cancer. There are a few that are screenable, And very bullishly, I make sure everybody's up to code with screening. And it's not like I force colonoscopies on everybody. I mean, there are other modalities as well if they're, not on board with it. But the point is that the things that are screenable, you don't sit around and wait. This is actually pulled straight from the Blue Shield website, by the way, and they got this wrong. I mean, women should have pap smears at 21, not 25 to 39. They should be ashamed of themselves. But all these other ones, so colorectal screening moved to 45 from 50 because the rates of rectal cancer are going up in the US. I mentioned prostate cancer screening being a big mess, and there are some doctors that don't do any. So the digital rectal exam is lousy. You put your finger in a rectum and you hope that small little piece of the rectum, which is like the size of a walnut, is hard and touches your finger. You're gonna miss so much. If you have 10 doctors do it, you're gonna get 10 different answers. Beyond that, there's the PSA, right? So the PSA has its problems. It's sensitive, it's not so specific. Okay, it has its problems, but the thing that actually works well with PSA screening is that you can trend it. And if you combine that with full body MR, I can ask my radiologist guy, Dr. Washer, hey, what's the size, what's the volume of this guy's prostate by MR? And then they can report back an expected PSA. So then you can compare your PSA trend, we call it PSA velocity, with your expected PSA and then say, okay, this raises an eyebrow. Breast cancer screening, so 40 plus, that's when the decision should be brought to a woman every 1 to 2 years. We start at 40 and we do it every year. Higher risk patients, we add 3D mammography on top of it, so you can use higher technology to really make sure you're not missing anything. Dense breasts, they all get supplemental ultrasounds for added sensitivity. Okay. So I want to maybe leave you with this. There's a new test out there called the Gallery test. So I mentioned 5 cancers, right? There are hundreds of cancers that can knock you on your butt, right? You're living your game, you're doing your thing, you're living a great life, you're vegan, you're healthy, you're active and you're fit, and then life throws you a curveball and you get pancreatic cancer. We can wait for the right chemotherapy to come forward with pancreatic cancer, right? And I'm optimistic in my medical community. But I can tell you what works a lot better. It's catching things super, super early, and then you can intervene upon it before it spreads or before it actually poses a problem. So this new test right now is a blood test. You can draw blood, and it looks at cell-free DNA with something called methylation signals that associated with 50 types of cancers. Pooled sensitivity, 93.5%, is extraordinary. The ability for this to detect a cancer, and remember, this is all stages. So, but what's really powerful in my mind is everybody's doing what they're supposed to do in my clinic. They're all up to speed with their cancer screening. Then they say, Dr. V, what's next? What about all the other cancers out there? Should I just hope I don't get it? So I say, okay, well, this is really good for its negative predictive value, NPV, which is, it's different than sensitivity and specificity. It tells me that if you do get a signal, or in this case, if you don't get a signal, is it a real signal? So if you take 1,000 patients and you run this test on them and there's no cancer cell detected, the true negative is 98.5%. So the negative predictive value of this test, I can say with very high certainty, if all their screening is up to speed, their blood work is optimized, inflammatory markers are okay, and we have a negative predictive value for a Gallery test of 98.5%, you're good. Come back later and we'll repeat this every year. So this is rapidly becoming standard of care, started in concierge practices, because insurance doesn't cover it, but that's going to change. Okay, you want to wrap it up? Does anybody want to stay?
Yeah.
Okay. Okay. So I mentioned I'm a big fan of full body MR imaging. I think it's the future of modern medicine. That's why I want to build one here. Pernuvo has this in the Los Angeles area, and they're spreading like wildfire. Full body MRIs now can take 60 minutes or less. So you still have the sound of magnets, it's loud, it's claustrophobic, but within an hour or so, you can get head to toe. And you can do these fancy overlays to look at hippocampal size of the brain and infer a risk of Alzheimer's in certain patients. You can do the visceral adiposity profile that I talked about from a body comp. So you can see if they have visceral fat, which is very inflammatory. And what I think, this is supposed to be up, again, just how it translated. But AI is really rapidly eliminating this noise. So one of my guys, so again, Washer works for Pernuvo as well, and he reads scans. And I asked him, like, what is the probability of having incidental, non-specific stuff that has to be chased down? This is the fear. Oh, Dr. V, I have a cyst on my kidney, and now I have to go in for more testing, and it's like irrelevant testing. He said 10, 15%. Which is really not bad. So for all the patients I know that get full body MRI scans, it doesn't have to be every year. They love it. They catch things, right? I had one woman literally down the street from here who we picked up a splenic artery aneurysm on her, 2.5 centimeters, surgical size for the surgeon in town, in here. She went to Cedars and had it repaired. I never would have picked that up unless it was bleeding. She's active and fit, right? And at some point, so she sat with the radiologist at Pueblo Radiology and said, what should I do about this? And he said, well, why don't we repeat another one in 6 months? And she said, appropriately, because they're very smart, what's the probability that's going down in 6 months? And he said, well, close to 0. Okay, because that's what aneurysms do. They get worse and worse and worse, like a distended balloon, and at some point they pop. So she went down, got a second opinion from one of the leading vascular surgeons at Cedars, and he said, absolutely, let's fix it. Now she's living her life, right? I mean, that's just, it's an N of 1, so take it with a grain of salt, but we have tremendous success stories. Nobody wants to be a statistic on the wrong side of the bell curve. Okay, so metabolic, I do a lot of analyses on metabolic health because it portends cardiac risk, cancer risk, obesity and overweight issues are extremely tightly correlated to a whole slew of cancers, and you guys obviously know heart disease, strokes, even Parkinson's and Alzheimer's. So here are the things that I look at. I look at A1C, fasting glucose, insulin levels. These are things that you probably are aware of. Continuous glucose monitor for patients that are pre-diabetic, so I can help optimize their diet, minimize foods that cause high swings and spikes. Uric acid can contribute to high blood pressure. Homocysteine level, this kind of gets into the methylation stuff, which I learned more about when I was kind of playing around with integrative medicine. But homocysteine can cause irritability on the endothelium and ultimately affect turbulence on blood vessels, and that can create plaque. So all the good neurologists and cardiologists now are checking homocysteine for their patients with strokes and heart attacks. And by the way, I mean, if someone has high homocysteine levels, there are very easy fixes for this. You just put them on methylated folic acid, dependent on which mutation, and if you do genomics, you can figure that out. But the fixes for these things are not bizarre. Sometimes they're extremely simple. This is interesting to me. I'm not going to mention those, but CPET testing, cardiopulmonary exercise testing, is a VO2 max. So if someone's physical ability to exert and move oxygen throughout their blood correlates well to their survival, then I want to trend it. And we do. This is a VO2 max machine. Has anybody checked their VO2 max? Has anybody, you see professional athletes do, you hop on a treadmill or you run and you wear a gas mask and you monitor carbon dioxide and oxygen delivery. And at some point you hit a lactic threshold, lactic acid builds up and you start freaking out. I did this myself as part of a presentation in residency, kind of like Tim Ferriss style, just using myself as a guinea pig. And my heart rate went to like 210. I started spazzing out when I couldn't get air. But it gives you a really important metric. And VO2 max can be influenced, increased with the right training, and it also goes down with age. So if you're the kind of person who's thinking, what sort of functional status do I need when I'm 60, 70, 80 years old to take care of my grandkids and live the life that I want to, knowing your VO2 max and working backwards can be extraordinarily helpful. Okay. This is what I'm building down the street from my office. So this is beyond just a classic DEXA scan, which looks at bone density or bone mineralization. It also looks at body fat, and you calculate these complex metrics. But the thing that I like, because it's trendable, is VAT, visceral adiposity tissue. So I intended to skip over this, but I just want to say that I spend a lot of time talking about nutrition with my patients. And I used to think of it as this complex thing. This is me back in I think before medical school. I remember sitting at a coffee shop writing on a napkin thinking I could figure this equation out. And now I think about it more simplistic, but this can be another lecture in itself. Exercise helps everything. There's no question about it. I want to run through this with you because this is fascinating. So 122,000 patients, retrospective cohort study for 15 or so years. They're looking at treadmill stress testing data, and you can correlate that to VO2 max testing with a little mathematical conversion. So we have all these VO2 max data points, and then they start going back retrospectively and looking at their comorbidities to see what lines up. And we do Kaplan-Meier all-cause mortality statistics on it. And this is so powerful. I know I wish this was bigger, but if you break your physical fitness level into quintiles, low, below average, all the way up to elite, like Lance Armstrong style, and you take a patient, this is a hazard ratio, but on a logarithmic scale, and you take them from low physical fitness to below average, that's not that hard to do. Like my mom would fit into that, right? Anybody can do this, yeah. You change their mortality 50%. So 50% decrease in death by making that small adjustment, right? And what's fascinating is, and you can see this across the spectrum, it continues to go down, but you get less bang for your buck if you're already an ultramarathoner and then you become Lance Armstrong. But the powerful thing is, look when you compare those variables to smoking, to diabetes, 40% increase, 41% increase. We're talking about a 5-fold increase, or I should decrease in mortality by going from low to elite. So that's a 500%. Compare 500% versus 40%. So really, the new buzz in the longevity world is you have all these things that matter, but what matters most? And most people nowadays will say that move-in, physical fitness matters the most. And then this is just I wanted to focus that VO2 max over here goes down even in elite athletes as we age. So you can reverse engineer the math and figure out what do I want to do, how much energy, how much oxygen transport is required to do that, and then figure your training regimens. So as part of my little side hustle, HealthSpan Montecito, we have an exercise physiologist who's going to put these consultations together for our patients, and then I jump in there and I join them. And I'm all about sort of getting all the right people together in a room and having this team approach. So having your primary care doctor talk to the exercise physiologist, talk to your nutritionist, talk to the radiologist who are reading your per nuvo scans, and you all just sort of come up with an output for your game plan is the future of medicine. Okay, and this is actually really quick. I don't spend much time talking about this. This is Dr. Mance over here. But I've gotten more interested in this word resilience, and I can tell you what it means to me. You know, sometimes I feel like I'm just dodging bullets. I'm gonna jump over here. All day long, right? You have stress, text message, all this kind of stuff. And so how do you maintain resilience? So a few sort of ideas that I have, right? So meditation I just started doing, I think it's fantastic. Breath work, exercise can help increase your heart rate variability, your parasympathetic nervous system, so you get less of a stress response. If talking to somebody is your thing, that's amazing. If being on the right medicine and SSRI is your thing, that's incredible. I'm a master of avoidance, pathological master of avoidance. I even read a book. He's given me some audiobooks, but one of them was dodging energy vampires. What do you do for those people that are just sucking your energy? And my solution is keep them out of your life. But everybody has a different resilience pattern. And the point is that it's not good enough to just build your life up. You have to maintain it. And if you're in a toxic environment and your stress levels are through the roof, it's going to come crashing down. So this is my dream. Wellness report cards for patients. You come in, you analyze their stuff. Okay, I'm going to revisit your relevant genetic history. Where we are from a cardiovascular, metabolic, cancer screening, are you up to speed with everything you need? Fitness metrics, VO2 44, okay, great. Can we do better? Dietary, where are you? Okay, let's tweak it, let's hack it. Should I bring in a nutrition at this point, or are we okay where we are? Sleep is another thing that I didn't talk about because of time, paramount. And then, of course, the emotional state. I mean, what's the point of growing old if you're not happy along the way? But this is what I think primary care should be. So take-home points. Define your goals, define your risk. Everybody's risk is different. You got to be the one that defines how much you want to dive. I have patients who come in and they're very clear and they say, Dr. V, I want to see you once a year. And I don't even want to see you once a year. I want to use you as an insurance policy. You'll be in the ER if I have a heart attack. I have some patients I don't even know what they look like. Others come in every day. Like literally, I hear from patients every day, some of them. So each variable should have a plan. And I'm not talking about a plan that's 3 to 6 months. What's your immediate plan? What's the follow-up? I try to shoot 2 sigmas, the far right of the bell curve for each problem. I try to make it as simple as possible, autopilot it whenever possible, so you don't have to think about things. Protect your gains, this is where resilience comes in, and then live your life. So I put a lot of upfront effort into my patients. That's why I only have 200 of them. But they were extraordinarily healthy. And then they go out and they live their best life. And if I don't hear from them, I know that they're cared for, they feel good. If they need me, they'll reach out. But otherwise, they're doing their thing. I'm not trying to foster codependencies. So again, I don't think of the goal having patients be bodybuilders at 90 and popping, hormones inappropriately, right? We're just looking for blue zone sort of stuff. And this is old medicine, by the way. So now it's participatory. Okay. That's it, fellas.